Hi, this is Rich Polin, speaking to you from New York City, from Columbia University, and I'm delighted and honored to be addressing you today. I want to thank Bill Chan for inviting me to talk about an important topic, and that is bronchopulmonary dysplasia. How can we prevent it or decrease the incidence? So these are my disclosures. I have some research support from the NIH for a topic that's unrelated to this lecture. And I do receive consulting fees from Fisher Paykel for their non-invasive ventilation. So whenever I talk about the future, the first thing I do is go to my local seer in Englewood, New Jersey, where I live, and her name is Esmeralda. And she has a small store in Englewood where she also does tattoos. And I went there and I said to Esmeralda, what can I speak about the future of bronchopulmonary dysplasia? And she replied, well, I don't know much about bronchopulmonary dysplasia, but here are a few things that may help you. That there's no such thing as gentle ventilation, although some ventilation strategies may be gentler than others. The best way to prevent BPD is to avoid or minimize the duration of mechanical ventilation. And strategies which avoid intubation and positive pressure ventilation. Here I'm talking about the non-invasive strategies like CPAP or high flow nasal cannula, and which enhance the likelihood of success with non-invasive ventilation. For example, caffeine should reduce the incidence of BPD, and that made sense to me. So here's my outline. I'm going to spend just a slide on the first two topics speaking about the pathophysiology of BPD and some successful and not successful prevention strategies. I have a single slide on CPAP, avoiding mechanical ventilation. I will address caffeine and try to talk about the controversy of when to start caffeine. Then I'm going to talk about surfactant administration. And as you know, the new sort of in vogue way to administer surfactant is through a thin plastic catheter, commonly called LISA, less invasive surfactant administration, or minimally invasive surfactant treatment. LISA is the more correct term. Then I'll talk about resuscitation and why it's very difficult to do a resuscitation on a fluid-filled lung, and finally end up with two newer interventions to decrease BPD. Those are sustained lung inflation and dynamic PEEP. So this slide looks at the three main predisposing factors for bronchopulmonary dysplasia. On the left, you can see lung immaturity, which goes far beyond the surfactant system in the lung. It also includes other structural abnormalities and host defense impairments. Chorioamnionitis is important because chorioamnionitis markedly increases the risk of BPD. At the same time, it decreases the risk of RDS by increasing production of surfactant proteins. And finally, is the issue of genetics. And I can tell you that we still don't understand the genetic causes of BPD. It's probably multiple genes involved. But all of these three work together to increase susceptibility. And when the baby's born and taken to the NICU, they're exposed to a lot of potential toxicities causing lung injury, including how we resuscitate the baby, oxygen, positive pressure ventilation, pneumonia, sepsis, and PDA. All of these lead to an inflammatory response. And the hallmark of what people call new BPD is inhibition of alveolarization and vascular development. Now, on the left part of this slide are strategies which people have suggested to decrease the incidence or lessen the severity of BPD. In fact, none of these are effective. I put the two in black because even in 2023, we still speak about gentle ventilation and permissive hypercapnia, although the data for those are relatively limited. I also want you to note that neither antenatal steroids nor surfactant have had a major impact on BPD. On the right part of the slide are interventions which have proven effective, and they include caffeine, which I'll talk about in a moment, postnatal steroids, which, and as you know, steroids like Decadron have been associated with increased neurotoxicity, vitamin A, which has to be given intramuscularly 3 times per week to be effective, CPAP, which I'll not talk about in this lecture, except for a single slide, and permissive hypoxemia. I look at the randomized trial of oxygen saturation targeting, and babies targeted to the lower saturation range had a lower incidence of BPD. This is my single slide on CPAP, which looks at a lot of the randomized trials comparing CPAP versus intubation and surfactant. It does not include the NeoCOSURE study from South America, but the conclusions would be the same, that CPAP lowers the risk of death or bronchopulmonary dysplasia. Here's the risk ratio and the confidence intervals. Not very impressive. And if there are questions, I can tell you why I think that in other people's hands, CPAP has not been as effective as it has been at Columbia. Well, on to caffeine. Caffeine is most widely, or one of the most widely used medications in the NICU. This is a survey from the United States of just about 900,000 babies admitted to the NICU. Number 1 and 2, not surprising, are ampicillin and gentamicin, followed by caffeine. And you see there's no FDA labeling for caffeine in premature babies. So I wish we were live and I could see a show of hands to answer the question, which medical specialists drink the most caffeine, in other words, cups of coffee in the world? And think about it for a second, but here is the answer. 91% of anesthesiologists drink caffeine or caffeinated beverages. And this is, again, a controversial question. When should you start caffeine in preterm babies? In the delivery room or soon after birth? Prior to extubation, infants are being ventilated, in every infant with apnea and bradycardia, and every infant receiving non-invasive ventilation. And in fact, the only one I consider as a partial truth, at least, for which there's not great evidence, is this one, prior to extubation in infants who are being ventilated. There are international guidelines recommending prophylactic caffeine. So the NICE guidelines out of the UK recommend prophylactic caffeine in babies less than 30 weeks gestation. Similarly, the European consensus guidelines recommend prophylactic caffeine for a similar population, less than 1,250 grams. But the Committee of Fetus and Newborn of the American Academy of Pediatrics do not expressly endorse prophylactic caffeine, but do recommend caffeine as applied in the CAP trial. And the CAP trial was mainly used prior to extubation and as treatment for apnea and bradycardia, but there were some babies who got prophylactic caffeine. So the question is prophylactic use of caffeine safe and effective for small premature babies? So I'm going to start with the CAP trial. And the CAP trial was one of the great trials done in neonatology by Barbara Schmidt. It was a randomized trial of using caffeine or placebo in the first 10 days of life. You can see the dose on the slide. The population was babies 500 to 1,250 grams. And what she shows, surprisingly, is that caffeine reduced the risk of BPD, shortened the duration of oxygen treatment, and shortened the duration of assisted ventilation. Unexpectedly, though, at 18 months, caffeine halved the rate of CP and improved survival without severe disability, defined as CP, severe bilateral hearing loss, cognitive delay or bilateral blindness. And I put cognitive delay because that finding did not persist. At age 11 years, caffeine reduced the risk of motor impairment. There's the relative risk and the confidence intervals. So in the CAP trial, the beneficial effects of caffeine were observed when it was used prophylactically, again, a small percentage, or to treat apnea, or to facilitate extubation. In subgroup analyses, starting it in the first 3 days, after day 3, there were short-term respiratory benefits, including the duration of respiratory support, but it did not reduce BPD after adjustment for prognostically important variables. So the conundrum or the hypothesis raised is that use of caffeine in the first few days of life will decrease the incidence of BPD and enhance survival without disabilities by decreasing the need for mechanical ventilation. But other than the CAP trial, there are no large prospective randomized clinical trials, and therefore we have to rely upon observational studies comparing early versus late caffeine. And the way you look or quantify the risk of bias in observational trials is by using the Robbins eye tool. And in this article by Nylander, published in Pediatric Research, they concluded the major risk of bias in the observational trials of caffeine were confounding by indication of patient selection, For example, infants receiving early caffeine to facilitate extubation are ready to be extubated, thus healthier than those receiving late caffeine. And what's called a mortal time bias. In the observational studies of early versus late caffeine, infants must have survived long enough to be included in the late group. If they did not, they may have been included in the early group or possibly not at all. And they analyzed each of the observational studies and assigned a score of no risk or moderate risk, serious risk, or critical risk for the bias in the observation studies. And you'll see that most of the studies had a serious or critical risk of bias. Does not mean these studies are of low quality. It means that there are inherent methodological problems. I want to start off with a very small randomized clinical trial. It's really a physiologic study giving caffeine intravenously through the umbilical vein at 4.4 minutes after birth, or when the baby was admitted to the NICU, 48 minutes after birth. It just tells you how quickly caffeine has a physiologic effect, because by 7 minutes after birth, minute ventilation and tidal volume were significantly increased in the caffeine group. The stimulatory effect of caffeine on ventilation was greater with advancing gestational age. So these are the randomized clinical trials that I could find giving caffeine in the first 3 days of life. The first is not strictly an RCT, it's a sub-analysis or a secondary analysis of the Schmidt trial, but it's very large numbers. And the conclusion, no effect on BPD after adjustment for confounding variables, and there's a serious risk of bias in that trial. The most recently published randomized clinical trial out of Egypt was prophylactic caffeine, started on day of life number 1, what they call therapeutic caffeine. In a therapeutic caffeine group, they may have received it or may not have received it. And in their multivariate analysis, caffeine did reduce the incidence of BPD, but not severe BPD. And it's a flawed study that was not blinded. I'll show you the study by Amaro on the next slide, and the very small study of Magrebi showed that BPD was decreased with early caffeine. Again, it's a very small study with a high risk of bias. And this is the Amaro trial, Amaro and Baccalari, in which they took ventilated babies and randomized them to receive placebo or caffeine. The study was stopped prematurely because of a higher mortality, not significantly higher, but higher, 12% in the placebo group, 22% in the caffeine group. And in terms of outcomes, none of the important outcomes like age at first successful extubation, total duration of ventilation, or total duration of oxygen was significantly different. All right, on to the observational trials in which caffeine was started on day of life 0. The first is a large study by Patel comparing day of life 0 versus day of life 6. And they showed no effect on the CPAP failure rate and no effect on BPD, critical risk of bias. And then a study out of Polin, day of life 0 versus day of life 1 to 10. A weakness in the study is they assessed outcome with questionnaires, but no effect on BPD with a critical risk of bias. These studies started caffeine in the first 3 days of life and compared it, starting it later on. So it's less than 3 days or greater than 3 days. The first by hand showed no effect on BPD. They also had a group that received caffeine very late, and that group had an increased risk of BPD. And then there's a study by Gupta, moderate size, no effect on BPD, showing that Bailey scores were increased with early caffeine, interestingly, with a critical risk of bias. All of these studies are observational trials, starting caffeine less than 3 days or greater than 3 days. You can see they're retrospective observational studies. Some of them, like the study by Dobson, extremely large. All of them showing significant decrease in death or BPD with a serious risk of bias. But I want you to know, in the Dobson study, they showed that mortality was increased with early caffeine, and the study by Taha showed that necrotizing enterocolitis was increased with early caffeine. And finally, 2 studies published in 2018, both with a critical risk of bias, both of which showed in retrospective observational trials, significant decrease in BPD. So what kind of recommendations can we make? So these are my personal recommendations. Caffeine should be used to treat infants with frequent or severe episodes of alkaline bradycardia. That makes clinical sense. It might be used prophylactically in babies less than 27 weeks gestation receiving non-invasive support who are at high risk for alkaline bradycardic episodes. And that's how we would do it here at Columbia, but it is not an evidence-based recommendation. Healthy VLBW babies greater than 29 weeks should not receive prophylactic caffeine. Prophylactic caffeine should not be used in the delivery room until we have better and larger randomized trials. And here's another use that we apply in New York, that caffeine might be used in fully ventilator dependent babies, but just prior to extubation. And we're not going to get that from another observational trial. It's only a prospective large randomized clinical trial that's going to answer that question. Now, some people question whether the dose of caffeine is right, and these are very small trials. You can see, let me go back one slide, you can see the number of babies in these trials. And if you look at the meta-analysis, the higher dose of caffeine decreased the risk of bronchopulmonary dysplasia. However, they're all small trials, and I would be cautious in applying higher doses of caffeine. In one of the trials, excuse me, the incidence of cerebellar hemorrhage was increased. Now we're going to talk about the golden minute. We stole that golden minute from trauma surgeons and ER doctors who talk about the golden hour of getting adults to the ER. But in a newborn baby, especially a preterm baby, lots of things have to happen in the golden minute. Baby has to initiate ventilation, either with our assistance or spontaneously. Pulmonary blood flow has to increase dramatically. At the same time, systemic perfusion has to be maintained, not so easy with a low resistance placental circuit removed. Tissue oxygen levels have to be high, and babies have to establish an FRC. In a premature baby, that's particularly problematic. You're starting with lungs that are fluid filled, a very compliant chest wall. Preterm babies have limited muscle strength and may have respiratory depression from maternal analgesics or anesthesia, limiting the ability of the baby to establish FRC. Now, one of the best drugs studied in neonatology is surfactant, and giving it through an endotracheal tube for RDS is clearly evidence-based. And this is not a new meta-analysis, but looks at the main randomized clinical trials of surfactant done quite a while ago, looking at natural surfactants, multiple dosing, prophylactic surfactant or early surfactant. And as you can see here, the relative risks and confidence intervals are all basically significant except for multiple dosing. Here are the number needed to treat, and the 95% confidence intervals for the number needed to treat can be extraordinarily high as 1,000. So giving surfactant through an endotracheal tube is generally benign, but there have been complications. In my lifetime, I've seen several babies with subglottic stenosis, a few babies with tracheal and pharyngeal perforations. Bronchial stenosis, uncommon. Lobar emphysema, not so uncommon when surfactant is given to one lung and not the other. And TE fistula, fortunately, very rare. So the alternative is giving surfactant through a thin plastic catheter or a nasogastric tube. And the question is that equivalent, better, or worse than the Ensure method? Remember, Ensure is intubation, surfactant, extubation. So the first person to do giving surfactant through a thin plastic catheter was Werder from Germany, and these were his conclusions in a small pilot study. Administration of surfactant through a narrow catheter is not less invasive at all. I think everybody who does it will say that's true even in 2023. And the smaller catheter cannot be used to ventilate the baby. In 2021, DeLuca and Bancalari published this critique looking at the trials of LISA administration, less invasive surfactant administration, And these were these conclusions after looking at the trials. Sedation and analgesia was variably used. There's no reason to believe that Lisa is less stressful, and I agree. Caffeine was not consistently used. Only two trials, up until the one I'm about to show you, included large numbers of babies less than 28 weeks gestation. There's also a greater loss of surfactant with Lisa. Surfactant distribution may not be equal with Ensure and Lisa, and CPAP is not delivered effectively through the Lisa catheter. So the first person or first group to pick up that technology or technique was a German group, which included Gopel and Cribbs, and they published three trials, as you can see here. The first, an observational trial showing decreased risk of BPD, use of the Lisa technique, no concurrent control. The two randomized trials by Gopal, again, they're all part of the same research group, and Cribbs, showed no significant benefit in terms of decreasing BPD. All three of these studies showed decreased need for mechanical ventilation. The second study by Gopal in the control of Finsburg Casino CPAP, and a study called NINZAP by Cribbs, the control group got intubation, ventilation, and surfactant therapy. So very different. Just one addendum. They did a follow-up of the NINZAP trial that Mailer published in 2021, and surviving infants in the Lisa group were assessed for developmental outcomes, and fewer infants in the Lisa arm had PDI less than 70. And for babies 25 to 26 weeks gestation, the MDI less than 70 was significantly less common in the Lisa group. Suggests that there may be some neurodevelopmental benefits to Lisa versus intubation and surfactant. Again, it's the only long-term follow-up study that I'm aware of. There have been a number of studies looking at the Lisa administration throughout the world. These are studies out of China and India. In two of the studies, they showed that BPD was lower with Lisa. In the other three studies, they showed no benefit. These three studies compared it to Ensure. The first two studies looked at intubation and surfactant, but only the study of Gupta, shown over here, used Ensure as recommended. Therefore, these data do not apply to units who are using Ensure correctly. And these studies out of Turkey, Iran, and China, three of the studies showed no significant benefit for BPD. One study out of Turkey showed a benefit to moderate severe BPD, and they all compared to Ensure without sedation. This is a meta-analysis by DeLuca and Baccalari looking at the outcome of mortality, non-significant. Here, looking at the outcome of bronchopulmonary dysplasia, also non-significant. And that brings us to the newest study by Dargaville at the University of Melbourne, published in JAMA Pediatrics in 2021. It's called the Optimist A trial. It was a randomized blinded trial of just shy of 500 preterm babies in this age range that we'd like to see, 25 to 28 weeks, who were supported with CPAP with an oxygen requirement of greater than 0.3 within 6 hours of birth. And I would tell you that we would not consider surfactant at this low inspired oxygen concentration. And in fact, death or BPD, not significantly different. They called it MIST, the same as Lisa. Here are the percentages. Here's the control over here. But the incidence of BPD was lower in the MIST group significantly. The need for intubation in the first 72 hours and the incidence of pneumothorax, here are the numbers, were both significantly reduced in the MIST group. The study was underpowered to assess mortality. Overall, it was 10% in the MIST group, 7.8% in controls. And in this strata, mortality in the MIST group was 15.6% versus 6.9% in controls. And that was significant statistically. And Isayama, who wrote the accompanying editorial, has questioned about the generalizability of the study. Only 25% of infants eligible for the trial were included. So what can we conclude? So Lisa is probably better than intubation and ventilation of an undetermined duration. It likely decreases the risk of mechanical ventilation. But at this time, I can say that Lisa is better than Ensure. All right, let's talk about resuscitation. And this is a classic study, often quoted done on preterm lambs of 127 to 128 days gestation, and 5 pairs of lambs were analyzed. 1 lamb in each pair received 6 big breaths, 6 manual inflations at a volume equal to inspiratory capacity. Before starting to ventilate them at normal tidal volumes, all lambs then received surfactant at 30 minutes of age. So here are the control animals that did not get those 6 big breaths. And if you look at volume versus pressure, measure of lung compliance, it improved over the 135 minutes of the trial. But in the animals who got the 6 big breaths, there was almost no response to surfactant. And the authors concluded, I think justifiably, that overzealous ventilation with large breaths, as sometimes happen in the delivery room, in an immature lung can decrease the response to surfactant, cause epithelial microvascular injury, decrease production of inflammatory mediators, and promote the flux of protein and fluid into air spaces. That's one issue. The other issue is that many of our babies, especially our preterm population, come from an environment where there is inflammation or infection. And this is a study by Alan Jobe and Ikegami, in which they injected either endotoxin or saline into the amniotic sac of ewes at 120 days gestation, at 100 days gestation. And then at 120 days, they ventilated the ewes for 6 hours. And over here, the blue are the babies born to, baby lambs born to mothers receiving saline. The orange are mothers who receive endotoxin, which increase the number of neutrophils, lymphocytes, monocytes, total inflammatory cells, amount of protein in the alveolus, and the production of the important free radical hydrogen peroxide, all were higher in the animals exposed to endotoxin, which shows you that there is a synergistic effect in causing inflammation in animals born from an infected or infected environment or inflammatory environment who are then ventilated. This is a thought hypothetical study that was published by Alan Jobe a number of years ago. And it took a hypothetical 1 kilo baby given normal tidal volume ventilation with PEEP of 5. So here's at birth, there's no PEEP, no tidal volume, and it's an airless lungs. In the first 20 breaths that go on, you're establishing an FRC, but just to the airways. All the tidal volume is delivered to the airways. That leads to overdistended airway. And what that also leads is to injury to airways, which is the first location for injury in babies who are ventilated. If you look now at 2 minutes, shown over here, you're also delivering some FRC and tidal volume to the airways, but you're beginning to ventilate the lung. And if you think you're giving 5 mLs, but only ventilating 20% of the parenchyma, because the rest of the parenchyma is fluid filled, that's like giving 25 mLs per kilogram to this small area, which causes focal overdistension and damage. And finally, once the fluid is absorbed from the lung or mainly absorbed, you're giving normal tidal volume ventilation to the airways, to the lung parenchyma, and that's considered non-injurious ventilation. So how does fluid get removed from the lung? We all talk about the vaginal squeeze, and we now know that squeeze probably occurs from pressure of the maternal birth canal on the diaphragm and not of the lungs correctly. In term babies, the fluid is reabsorbed through epithelial sodium channels or ENaC channels. Those channels do not exist in our small preterm babies. And then positive pressure ventilation, either spontaneous or administered by us, is an important factor in having the fluid reabsorbed. This is a great article by Stuart Hooper that, if you have time, I suggest you read it. Appeared in the Archive Diseases of Childhood in 2016, and looks at 3 phases of fluid clearance. And the top 3 pictures here are end expiration, and the bottom 3 are end inspiration. So the dark blue is the alveolus. Over here is the lung tissue with lymphatics. And over here, the red are the blood vessels. So at end expiration, the pressure in the alveolus and the lung parenchyma is the same. So there's no fluid being transferred to the lung parenchyma. At end inspiration, And again, that can be spontaneous or assisted by us. A negative pressure is created in the lung interstitium, causing fluid to move into the interstitium. That takes place in seconds or minutes as fluid is moved down the tracheobronchial tree and out of the alveolus. In phase two, which occurs over hours, you still have a negative pressure, not quite as much because there's some fluid in the interstitium of the lung, and more fluid moves into the lung. There's interstitium. At end expiration, if PEEP is not supplied, that that fluid can move back into the alveolus. And finally, over a period of days, that fluid is reabsorbed in the lung, is reabsorbed in lymphatics, and very little fluid has to move into the lung interstitium. So this is not a baby, but a baby rabbit, and it's studied by use of the synchrotron. And it shows you how when you ventilate a fluid-filled lung, mostly you're just ventilating the airways, and only over a period of time do you ventilate the lung parenchyma. And this is looking at an animal study, looking at where damage occurs in the lung. And here you have the damage is assessed by upregulation of an early response gene. It's one of the acute phase response genes. Here are the control animals. Here's animals receiving just CPAP. Here's animals that are ventilated with nitrogen. Here's animals ventilated with oxygen. So you see here, ventilated with nitrogen, there's some upregulation of that gene, signified by the black dots. And when you ventilate with oxygen, the black dots are then not only around the airway, but also in the lung parenchyma. What's the alternative? That is using sustained lung inflation. And in this synchrotron video, you don't see the airways at all, but you see the lung getting inflated. It's a slow administration of positive airway pressure. So people looked at this and said, wow, sustained inflation must be a good way to inflate the lungs, perhaps better than positive pressure ventilation. And so the first studies were to assess the efficacy of sustained inflation for resuscitation. And these are 24 preterm babies, about 28 weeks gestation, were given 1 to 3 sustained inflations for 15 seconds with peak pressures of 20, 25, or 30. So here we're looking at heart rate, saturations pre and post ductally, and cerebral saturation. And although the heart rate falls during the time they were inserting the nasopharyngeal tube, you can see the heart rate came back up quickly. Saturations responded very quickly, and cerebral saturations responded quickly, showing that it is possible to use sustained inflation to resuscitate babies, just as we would use with intermittent mandatory ventilation. This is the earliest study by Paz that I could find looking at the value of sustained inflation. It was a randomized clinical trial of 207 babies less than 32 weeks gestation with respiratory distress were randomized to a sustained inflation, 20 centimeters for 10 seconds, using a nasopharyngeal tube, or bag and mask ventilation, using a self-inflating bag and a face mask, but without PEEP. If the response to sustained inflation was inadequate, the pressure and duration was increased. And the study outcomes looked extraordinary. Let me go back one slide here. So the number of babies who were intubated in the DR, the length of respiratory support, and the incidence of BPD were all reduced in sustained inflation plus PEEP group as opposed to bag and mask group. You can see all the p-values were significant, which led to the SAIL trial. The principal authors were Marty Kessler, Harish Karpelani, Peter Davis, and Ratcliffe, including very immature babies. And they're arbitrary, and I emphasize the word arbitrary because they were measuring how much oxygen or air was getting to the lung. 15 seconds sustained inflation with 20 centimeters of water. And then if not successful, they increased the pressure. So they wanted 592 babies. It was stopped after 460 babies were enrolled because there was no benefit in death or BPD, and mortality was increased significantly less than that is mortality in the first 2 days in the sustained inflation group. So now I'm going to show you three meta-analyses, all of which have reached sort of similar conclusions. First of all, most studies use sustained inflations of about 15 seconds, but none of the studies measured how much pressure or volume actually got into the lung. It was just arbitrary, the sustained inflation that was used. Most studies use face masks. As you know, face masks are prone to obstruction and leaks. All the animal data used endotracheal tubes. And there was great heterogeneity in the quality and number and length of sustained inflations. So this is the first meta-analysis, 9 studies by Liz Foglia from CHOP, published in JAMA Pediatrics in 2019. And they showed sustained inflation increased the risk of death in infants in the first 2 days of life, but not death before discharge. This looks at their meta-analysis of death before discharge. Certainly there's a trend down here, but it was not clinically significant. But in the first 48 hours, it was. And this is a study out of Capadia for ILCOR, the International Liaison Committee on Resuscitation, published in 2021. And they showed that sustained inflation in babies less than 28 weeks in the first 2 days of life increased the risk of death, but not death before discharge. But the certainty of evidence was low or very low. This shows the increased mortality in the first 2 days of life. And this is a study published in 2020 from the Cochrane collaboration. Sustained inflation was not associated with death in the delivery room or death before discharge, but they concluded sustained inflation for resuscitation is not better than standard resuscitation using intermittent breaths and does not affect the incidence of chronic lung disease. So the question is does sustained inflation protect against lung injury? And some of that comes from an animal study by Hillman and Jobe, which they took fetal lambs still attached to the placenta and used 1 of 4 interventions, a PEEP of 8, 20-second sustained inflation, pretty high pressure, followed by PEEP of 8, mechanical ventilation at a normal tidal volume, or a sustained inflation, followed by that normal tidal volume ventilation. Again, the sheep were still attached to the placenta. Here, they're looking for acute phase response genes recognized by black dots. Here's the unventilated control. Here's PEEP, and you can see them around the airway, not surprising, but not in the lung parenchyma. Here's sustained inflation followed by PEEP, same finding as PEEP alone. But here is ventilation with or without sustained inflation, diffuse upregulation of acute phase response genes around the airway and in the lung parenchyma. And here it looks at it in terms of figures. Here are the acute phase response genes. Names are not important. The purple is mechanical ventilation alone. Here's mechanical ventilation plus sustained inflation. And basically, just looking at the purple and blue bars, they're all not significantly different, showing that sustained inflation does not protect against mechanical ventilation following that sustained inflation. And if I was doing an infomercial in the United States, I'd say to you, but wait, trying to entice you into a better offer, there's more. And one concept I sort of alluded to is that one size sustained inflation does not fit all infants. So this is another preterm lamb study in which the lambs were given just positive pressure ventilation, but no sustained inflation, a 30-second arbitrary sustained inflation, or an individual sustained inflation using electrical impedance tomography, which is a way of measuring the air that's getting into the lungs until 10 seconds after a plateau is reached, or 30 to 40 seconds after a visually determined plateau. And here are the results. Targeting volume equilibrium using electrical impedance tomography resulted in better compliance and lower resistance than an arbitrary sustained inflation that did not target lung volumes. So you can't look at studies that use the predefined sustained inflation and not know whether the sustained inflation is being delivered or not. And finally, I'd like to talk about a newer strategy that's being tested in human newborn infants, and that is a gradual increase in aeration at birth. So in this study, preterm baby lambs, 128 days gestation, received either no ventilation, tidal volume ventilation without an intentional recruitment, A sustained aeration, that's sustained inflation, so full aeration, using using the electrical impedance tomography, or ventilation with an escalating or de-escalating PEEP up to as high as 20 centimeters of water. All the lambs received poractin alpha and were ventilated for 90 minutes. So compliance, oxygenation, surfactant response were best in the lambs receiving PEEP escalation, de-escalation. Dynamic PEEP resulted in more uniform ventilation over time. Uniformity of ventilation was worse with sustained inflation. Dynamic PEEP has the lowest expression of early injury markers, while sustained inflation increased injury markers the greatest. So my conclusions about sustained inflation: any lung inflation can cause injury and inflammation, even just around the airways. Sustained inflation does not protect the lung from subsequent tidal volume ventilation. It may avoid mechanical ventilation. PEEP escalation and de-escalation represents an alternative strategy that's now being tested. I'm part of the DSMB for the Polar trial, and they've enrolled 100 babies so far around the world. It'll probably be a couple of years before we hear the results of that trial. So the best way to prevent BPD is to avoid mechanical ventilation and positive pressure ventilation. That's sort of obvious. The risk of BPD is reduced by caffeine, vitamin A, and Decadron, but Decadron has concerns, neurodevelopmental concerns. The use of Lisa mist, I think, is controversial, whether it's better than Ensure. Sustained inflation at birth is not efficacious and may increase early mortality, so I would not use it. A stepwise increase in PEEP is under investigation. So thank you all very much. It's been great to speak with you. And if you have questions, I'd be happy to answer them by email. I wish you all a healthy and successful 2023. Thank you very much.